What do gallstones and alcohol have in common? Hi, it's Dr. Fan here. Let's talk about pancreatitis. Pancreatitis is the inflammation of the pancreas. It has an incidence of around 4 in 10,000 and is most commonly caused by gallstones and alcohol. A number of other causes can be summarized in the mnemonic I get smashed, which stands for idiopathic, which just means I don't know, gallstones, ethanol or alcohol, trauma, steroids, mumps, autoimmune, scorpion stings from the South American Titius scorpion, hypercholesterolemia and hypercalcemia, ERCP, and drugs such as azathioprine, thiazides, and furosemide. A number of other causes that do not fit in the I get smashed mnemonic include anatomical obstruction, annular pancreas, pancreatic divism, choledochal cysts, IPMN, and other ampullary obstructions, and congenital, cystic fibrosis, and hereditary pancreatitis. Despite all these causes, there are two fundamental pathways to pancreatitis. 1. Toxins, such as alcohol, cause direct acinar cell injury, leading to zymogen, specifically trypsinogen, release. 2. Obstruction and edema, such as from gallstones, causes a blockage and increases in concentration of zymogens, leading to the premature zymogen activation. In both cases, the release and activation of zymogens leads to the digestion of acinar cells, which releases more zymogens, resulting in a vicious cycle of zymogen release and localized inflammation. This inflammation leads to the typical presentation of epigastric pain radiating to the back, because the pancreas is a retroperitoneal organ in contact with intraperitoneal organs. Other symptoms and signs include anorexia, nausea, vomiting, and dehydration, which manifests as thirst, concentrated urine, dry mucous membranes, and reduced skin turgor. In rare cases, the clinical findings of Cullen's sign, periumbilical ecchymosis, and Gray-Turner sign, flank ecchymosis, represent necrotizing pancreatitis and hemorrhage. There are a number of complications from pancreatitis which can be divided into local and systemic. The local complications include acute peripancreatic fluid collections, which can progress into a pancreatic pseudocyst, acute necrotic collections, which can progress into ward-off necrosis, retroperitoneal hemorrhage, abdominal hypertension with an abdominal pressure of greater than 20 millimeters of mercury due to fluid sequestration, gastric outlet obstruction, biliary obstruction and ileus, splenic vein thrombus found in 50% of necrotizing pancreatitis, which can then lead to enteric or colonic ischemia, and arterial pseudoaneurysms, which can lead to hemorrhage. Systemic complications include exacerbation of previous comorbidities and organ failure, specifically acute pulmonary edema, pneumonia, acute kidney injury, heart failure, and shock. Clinically, 10 to 20% of people with pancreatitis develop severe pancreatitis. Of this group, 10 to 20% develop necrotizing pancreatitis, which has a 10 to 20% mortality. The investigations for pancreatitis include blood tests and imaging, which are performed to confirm diagnosis, determine the cause, and assess for the complications of pancreatitis. Blood tests include lipase, which supports diagnosis, and calcium, lipids, and IgG4, which assesses for the cause. Imaging includes chest X-ray to assess lung complications, such as atelectasis and effusions, abdominal ultrasound to check for gallstones, and abdominal CT, performed 72 hours after onset of symptoms to assess for local complications, if clinically indicated. MRCP, ERCP, and EUS, performed when more common causes of pancreatitis are not identified, to further assess for other causes of biliary obstruction, such as microlithiasis, sludge, and IBMN. The diagnosis of pancreatitis requires two of the following three criteria. 1. Clinical. Epigastric pain radiating to the back. 2. Biochemical. Raise lipase to 3 times higher than the upper limit of normal. And 3. Radiological. Pancreatic enlargement, peripancreatic inflammation, pancreatic collections, or presence of pancreatic necrosis on CT. Pancreatitis can be classified in many ways. One common way is the modified Atlanta classification. This involves both a clinical and radiological component. The clinical component stratifies pancreatitis to mild, moderate, or severe, depending on whether there is no organ failure, transient organ failure lasting less than 48 hours, or persistent organ failure lasting greater than 48 hours. Radiological findings are divided into non-necrotizing, necrotizing, and acute, lasting less than 4 weeks, or chronic, lasting greater than 4 weeks. The findings of acute peripancreatic fluid, pseudocysts, acute necrotic collections, and ward-off necrosis can thus be summarized into this 2x2 table. The general treatment of pancreatitis involves intravenous fluid hydration, analgesia, and early enteric nutrition. Specifically, there is no evidence for the empirical use of antibiotics or decompressive ERCP in absence of concurrent cholangitis. There are specific management options to address the cause. For gallstone-induced pancreatitis, a cholecystectomy should be performed in the same hospital admission if the pancreatitis is mild, or wait until resolution of the pancreatitis, typically waiting 6 weeks if the pancreatitis is severe. For more information on gallstones, check out the links below. For alcohol-induced pancreatitis, abstain from alcohol indefinitely. For idiopathic pancreatitis, in patients with no suspected cause, based on the results of the previously described extensive investigations, a cholecystectomy should still be recommended if they have more than one episode. There are also specific management options for managing the complications of pancreatitis. 1. Acute pancreatic fluid collections. These are generally self-resolving over 1 to 2 weeks and do not require intervention. 2. Necrotizing pancreatitis. These are best left alone for delayed intervention. Early operative intervention for pancreatic necrosis has a near 100% mortality. 3. Infected necrosis. The clinical suspicions for infected necrosis is deterioration or failure to improve after 7 to 10 days, with gas in the collection on CT. The likely organisms are usually Escherichia coli, Klebsiella, Enterococcus, and Pseudomonas. Antibiotics is indicated in these instances, and the treatment of choice is broad-spectrum antibiotics using carbapenems, such as meropenem. Aspiration and culture may be helpful, but are not essential to the commencement of therapy. 4. Pancreatic pseudocysts and ward-off necrosis. These contained collections occur after 4 weeks and should be drained or debrided at that stage. There are numerous options, all of which aim to remove the necrotic material. Historically, the most common technique for drainage is the step-up approach, which involves inserting a retroperitoneal drain to drain the collection, and gradually replacing this with larger and larger drains until all the collection is drained. Related to this is the video-assisted retroperitoneal debridement technique. This involves inserting a camera along the drain tract and using forceps along the same track to remove necrotic tissue. An alternative to this is the endoscopic drainage technique. This involves using a gastroscope to locate the pancreatic collection and opening up a tract from the stomach or duodenum to the collection, then keeping it open with a stent so that the pancreatic collection can drain into the gastrointestinal system. This has now become the preferred approach and is successful 70% of the time. If none of these less invasive options work, then a cystgastrostomy may be required. This involves laparoscopy or laparotomy, opening up the anterior and posterior stomach wall into the pancreatic collection, then using a stapler to formalize a tract into a cystgastrostomy so that the collection can drain into the stomach, much like the endoscopic approach, but performing an operation. Well, I hope that you have learned something new. Please listen to this again to reinforce your learnings, because repetition is a key part to learning new information. And please remember to like, subscribe, share, and comment for more videos.